Welcome to bioMaryU Lab Week Virtual Symposium. We're excited that you're joining us either live or on demand. We'll begin with a presentation by Dr. Nicole Hubbard from ProMedica Laboratories and University of Toledo about the role of lab team and blood cultures and continuous improvements in diagnostics. Dr. Rosemary Shea of Keck Medical Center will walk us through a few case studies that address challenges you most likely face with susceptibility testing and breakpoints. We'll also have a presentation about the Vitek MS Prime bioMaryU's next generation MALDI-TOF analyzer for organism identification, which will be followed by 4 presentations about antimicrobial susceptibility breakpoints. bioMaryU's Dr. Andrea Prinzi will first address changing breakpoints for antimicrobial susceptibility testing, and Dr. Lauren Hunt will talk about the breakpoint update process. Eric Berger will talk through the Vitek 2 breakpoint update that should help ease the burden on the lab to assess compliance with current CLSI FDA breakpoints. Then Dr. Brian Rowe and Dr. Hunt will conclude, teaming up to give a clinical perspective on updating breakpoints. Thank you again for joining us. If you need to step away, please know that these presentations will be available on demand for your convenience after they air today. We hope that you know how important the work is that each of you do and the role that you play as the pulse of patient care. Thank you for celebrating Lab Week with us.
Hi, my name is Nicole Hubbard. I'm a medical director of infectious disease pathology at ProMedica Laboratories in Toledo, Ohio, and vice chair of clinical pathology at ProMedica Laboratories. As well, I'm an assistant professor at the University of Toledo College of Medicine and Life Sciences in the Department of Pathology. And today I'm going to talk to you about the crucial role of the lab team and blood cultures, the continuous improvement in diagnostics. For disclosures, this talk is supported by bioMaryU, but I have no other relevant disclosures to let you know of. The objectives for today's talk are to summarize our recent blood culture instrument transition due to supply chain shortages during the COVID-19 pandemic, to discuss microbiology's critical role in antimicrobial stewardship. Then we will briefly review blood culture volume recommendations. And last, I will demonstrate the use of automated blood culture volume monitoring. So just a little bit more about me and my laboratory. ProMedica Healthcare System has 10 acute care hospitals and employed physicians and clinical groups that lead to significant outreach volumes. The largest hospital of the system in Toledo, Ohio, has nearly 800 beds. Additionally, we have a pediatric hospital in Toledo that provides NICU care, oncology services, and cystic fibrosis care. Our total microbiology test volume in 2022 was almost 550,000 specimens. In microbiology, we employ 48 people, which includes both microbiology processors and our technologists and medical laboratory scientists. I would like to start by sharing this quote. No microbiological test is more essential to the clinician than the blood culture. The finding of pathogenic microorganisms in a patient's bloodstream is of great importance in terms of diagnosis, prognosis, and therapy. I think it is incredibly important to remember how much impact we in the lab have on patient care, and specifically how critical blood culture diagnostics are. I'm sure you are all aware of the variety of supply chain shortages that occurred during the COVID-19 pandemic. There were numerous news stories and websites covering the topic, including the American Society for Microbiology, the College of American Pathology, and even Nature. Laboratories across the country really scrambled with both COVID-19 diagnostics and numerous other supplies. What's unique is Nature reporting that even research labs and scientific labs were struggling, and it reported attempting to borrow supplies from each other and sometimes even from clinical lab colleagues. In 2020, the American Society for Microbiology partnered with the Association of Supply Chain Management to collect data on some of these shortages. 147 CLIA labs were part of the reported data collection from September 2020 through mid-January 2021. I want to really focus, though, on the results reported for the non-COVID-19 diagnostic shortages. During the data collection times, you'll note that supply shortages improved in some areas of the clinical microbiology laboratory, but in other areas, the problems worsened. Just look at the very last week of data from the website, and almost half of labs experienced shortages for basic bacteriology testing. Over a third struggled with supplies for sexually transmitted infection diagnosis, which is a real public health problem. Mycobacterial testing, such as tuberculosis testing, was affected in just under a third of the labs. Approximately 20% of labs experienced shortages with fungal diagnostics. And the least affected area was parasitology, with only about 10% of the labs reporting shortages in testing supplies. So our story really began in 2021 when we received notice from our vendor that the blood culture bottles we used were going to be on strict allocation, and we would not be able to get enough blood culture bottles for our expected daily testing volumes. Our allocation per our vendor was going to be set at 100 sets of blood culture bottles per week. Our need is approximately 175 to 200 sets per day. We analyzed our inventory and we had approximately a 2-week supply on our shelves to use. So this was an incredibly urgent problem for us to address. Interestingly, after our crisis, the American Association of Clinical Chemistry put out an article about supply chain meltdowns and how laboratories used laboratory and diagnostic stewardship efforts to decrease risks that these shortages would have on patient care. This article discussed the coordination of physicians, the laboratory, electronic medical record analysts, and others to address an impending shortage of blood tubes, especially citrate tubes, to implement more diagnostic stewardship efforts to conserve their supplies. And this was interestingly one of the first things that we thought of as well, and I'll describe that next. Ultimately, we rapidly implemented supply conservation strategies through multiple steps. We sent out communication to our medical staff about the shortages through a memo, a banner in the EMR, and direct communication with our lead emergency department contacts to do things like not draw any blood culture bottles without an order, which sometimes happens, and ensure that the physicians, as emergency department physicians are common users of blood cultures, were very aware. We also used system-wide coordination within the laboratory to track blood culture bottle supplies and help move those around to use them most effectively for things like using the bottles most close to the expiration date first to minimize any potential waste that we would have. And finally, we did obtain another bottle size, which the vendor had for quick validation and use for sterile body fluids, since we inoculate the sterile body fluids into blood culture bottles ourselves, so that we could free up the supplies at our core laboratory and send to our clinical colleagues and really have less overall impact on blood draws, since we can control our own employees and putting it into different bottle size and amounts and such. So this just shows the example of the electronic medical record banner, which is the big red banner here that says, ProMedica Labs is experiencing severe shortages in blood culture bottles and supplies are likely to run out in days. In order to conserve supplies, please review the clinical need for all blood culture orders. An alternative plan for blood culture collection is being actively worked on and will be communicated in the near future. And we thought it was really important to update this banner as we went along the process, but this is the first part of it that went into place. Additionally, we coordinated with our infectious diseases physicians to create some electronic medical record guidance when ordering blood cultures. When entering a blood culture order, a pop-up would appear and remind the enterer of the shortage and to ensure that they clinically needed the test. Once they click continue, order entry guidance or decision support popped up and included common criteria for actually needing blood cultures, and they had to pick one of the options, as well as times in which repeat cultures would not be indicated. We included probable collection contaminants, like when patients had 1 out of 2 or more blood cultures drawn and only one of them was positive, and it was documented to be a known possible contaminant. And then for the documentation of gram-negative bacteremia clearance in patients who are clinically improving with suspected urinary sources. We did leave an other option available for our clinicians, and it was not a hard stop for concerns of patient safety. So they'd always actually be able to order a blood culture if needed. They just had to do a few clicks. With these steps to decrease orders, which did show a reduction in our daily use, finding supplies from a laboratory who had recently switched blood culture systems and had some bottles left over on their shelf, plus a few allocations, we were able to prolong the period for which we had supplies. But we knew we had to consider what long-term management plan would look like, because who knew how long those shortages would last. We engaged in discussions with other laboratories who were experiencing those same allocations and shortages. Other plans of management that some people considered were concepts such as inoculating only anaerobic bottles because they were easier to get, and allowing only 1 blood culture set per patient without infectious disease consults. We felt that this decision in terms of bottle type and number of sets needed to be maintained by the clinician. With being such a large system, it would be challenging for us to do it another way. So we reviewed our options and came up with 2 basic concepts. Our concepts were, we're going to have to either refer out blood cultures, or we have to get in a new bottle from a different vendor, educate on collection, and roll out new bottles that we can at least manually incubate. If we used a reference lab, we could maintain the use of an automated system, which shows quicker recovery of organisms and use less technical labor, but would have had to send to multiple labs due to our high volume of testing. No single reference lab or local lab could take on our volume, which would result in problems with maintaining more than 1 blood culture bottle type, creating bigger drawing problems in education. It also would lead to delayed incubation, which is also important in the recovery of pathogens. It would create issues with result management because we didn't have a test that a reference lab could send results back to with preliminary steps before receiving a final result. And then obviously no growth results would be delayed as well. Plus, obviously, the significant cost of having to maintain that. Manual incubation would allow us to maintain single collection devices, manage our results easier as it would appear in the same manner to the clinicians and cause less confusion, and maintain our antimicrobial susceptibility testing reporting to follow hospital protocols in pharmacy formularies, but would also be incredibly laborious, still delay the critical values and no growth results, and also would have significant cost associated with it. Ultimately, we decided on manual incubation with a bottle switch. Overall, the manual process lasted approximately 6 weeks, where we incubated 8,400 bottles manually. The process we followed was to receive the specimen, load it in newly bought racks for the incubator, visually check and agitate these bottles at 12 hours, 24 hours, 36 hours, 48 hours, and then daily. On day 1 and 5, all blood culture bottles were blind subbed and gram stained, and then got a final no growth at 7 days when reviewing the bottle and the plate for lack of growth. So this did delay our no growths by at least 2 days. This slide contains some pictures of the different things we did to try and make the process as efficient as possible and show the work that went into doing this large-scale manual blood culture incubation that we had to do. Now, all laboratories typically have policies on offline incubation, but typically people are expecting to cover only rare sets that need to be incubated offline because of things like receiving bottles from a different vendor from an outpatient world, or an instrument continuously flagging a set as positive when it is not, that you would take it off and pull it offline. But because this was a much bigger process, we had to have people from other departments in the laboratory help us. We used phlebotomists to do things like put together syringes that would be used for the blind subbing process. We had people mark plates and gram stain slides to use them for multiple patients to try to conserve supplies in incubator space. We created a worksheet that detailed everything that people had to do during the day to make sure everything was checked off and done correctly for each shift. And then the last picture is the picture of the incubator at the end of 6 weeks, almost full with blood culture bottles and racks. We were about to run out of room. It also shows that we had this numbering system for the racks to make it easier to find them, and note cards used to identify orders of the bottles within the racks so that the techs could easily find the patient bottles they were looking for. So after going through this period and knowing how much information there was out about shortages, we really wanted to put some data together that would show the patient care impact and laboratory staffing impact that these shortages created, because that topic really hadn't been well looked at the time. So we presented a poster at the American Society for Microbiology microbe meeting in 2022. We reviewed data from before our manual incubation, during, and just a little bit of data once we were out of manual incubation. We chose to look at time to positivity using the time of reporting the gram stain result, which would be the same time we would report a critical value, the overtime hours incurred in the department, and additional costs by analyzing our typical ordering patterns and comparing it to this time period, which cost approximately $44,000. We also included data from supply loss, which was quite significant since we were no longer to use our molecular blood culture identification pouches and without re-verifying them on our new bottles, and they expired before we were able to complete the process. It isn't surprising to me at all when looking at the results that overtime hours within the department were affected. Before the manual incubation period, we were utilizing about 192 hours of overtime and work premium time per pay period. However, during it, we used about 326 hours per pay period. In this time, we included hours of employees of the other departments, such as the phlebotomists we previously discussed, and we had one particular hematology and flow cytometry employee that would help do blind subcultures and make the spots on the gram stain slides for our microbiology techs to stain and read. The difference in averages was statistically significant. As we also expected, the average overall time to positivity was significantly increased during the manual incubation of bottles. It was about 23 hours in the pre-manual period and near 53 hours during it. The bar graph on the right shows those results by week. New bottles were started to be received in that last week of August, slowly at first, and then it shifted to predominantly those new bottles within a few days. The last bar only included a partial week, so we didn't include it in our analysis, but even from a few days, we can see, because we started the new system on October 13th, that the turnaround time or time to positivity significantly decreased. So we personally like to say in our laboratory that we never let a crisis go to waste. Before the pandemic, we had really already started our analysis of replacing blood culture instruments. So part of the work had been done, including some of the floor plan discussions, how many instruments we would need and beyond. So we utilized this opportunity to switch bottles, obtain a new blood culture system, validate it, and go live within an approximately 2-month time frame from start to finish, which is a huge process in the laboratory. Most things take significantly longer. So I want to send a big thank you to my team who may listen to this and worked tirelessly through this time. I've pictured some of them here from left to right. I have Sherry, one of our main microbiology processors, Megan, who was the department manager at the time, Fran, who was the lead blood culture tech, Mary, who was one of our lead techs with the most experience, and then myself on the very right. And again, this picture does not include administration, hospital administration, and IT, who was very helpful to get this done as quick as possible for patient care. So now as we move on to the next part of the discussion, I just want to remind everyone of this quote again. It is incredibly important to remember how critical blood cultures are for patient care. So switching gears, let's talk a little bit about microbiology's role in antimicrobial stewardship. This figure comes from an article from 2017 from the Journal of Clinical Microbiology. Massakar and colleagues discussed the concept of diagnostic stewardship's connection to antimicrobial stewardship. It starts with the patient, who is obviously evaluated by the clinical team, and then utilizing the right test on the right patient at the right time leads to those results from the microbiology laboratory that can get acted upon by the clinicians and lead them to the ability to treat the patient effectively with the right interpretation of those results, using the right antimicrobials for the right period of time. So it feeds back to the patient. And this article's really, the focus was really on rapid diagnostics, but it really applies to all tests, as effects from things like overculturing urine and respiratory tract samples, as well as poor wound culture collection, can lead to inappropriate therapies and hinder these antimicrobial stewardship efforts. When looking deeper at what antimicrobial stewardship is, there are what are considered the 5 Ds of antimicrobial stewardship: diagnosis, drug, dose, duration, and de-escalation. And each D can be associated with different things that we were doing in the clinical microbiology laboratory or even the main laboratory to impact antimicrobial stewardship. This concept was discussed in a 2016 article in Clinical Microbiology Reviews. For diagnosis, it is imperative that we make and document the correct diagnosis through efforts in appropriate specimen collection, rapid testing, sometimes the use of biomarkers, and diagnostic stewardship. For drugs, it's important that the correct antibiotics are utilized during empiric and definitive therapy, which we will help achieve with our cumulative antimicrobial susceptibility reports, cascading of antimicrobials, antimicrobial resistant marker reporting, and surveillance of emerging and multi-drug resistant pathogens. For dose, it is important that they use the right amount of drug for the site and for the diagnosis. And so reporting MICs for correct dosing and using up-to-date breakpoints is incredibly helpful here. For duration or length of time of therapy, we can use biomarker testing sometimes, and then involvement and engagement in protocol development. For de-escalation, this is once they use new information and reevaluate what's going on in the patient. So this is where our appropriateness and our reports of microbiology, not including things like normal flora, specifying when there's likely contamination, and comments to aid in clinical guidance on those reports. This is a figure from the article showing those different steps within the microbiology laboratory. And again, it starts with the patient who gets evaluated by the clinical care team using that appropriate test and avoiding an inappropriate test. Next step is a focus on specimen collection, followed by the things we do in the labs, such as gram stains, culture, identification and susceptibility testing, and then issuing final reports, sending out further testing if needed, and feeding all that back through information technology, utilizing alerts and direct communications with infection prevention and control, our public health partners, and again, back to the care team who can take that back to treat the patient. But I'm really going to highlight the key for this talk, which is specimen collection. It's an incredibly crucial step to improve antimicrobial stewardship. More efforts, time, and improvements in specimen collection are vital to quality patient care. This article from Dr. Susan Harrington at Cleveland Clinic discussed the unseen issues with specimen collection. She stated, importantly, any diagnostic test starts with the collection of the appropriate specimen from the patient at the right time with the proper technique. What I found really interesting is she mentioned a philosopher named George Berkeley, who posed the idea that objects exist only if someone is there to perceive them, and later rephrased that thought to ask, if a tree were to fall in a forest and no one is around to hear it, does it make a sound? There are many errors in specimen collection that go unrecognized in healthcare. I'm sure many of you are very familiar with this quote as well, that the volume of blood that is obtained for each blood culture set is the most significant variable in recovering microorganisms from patients with bloodstream infections. This statement occurs in many literature studies, and we're going to spend a few minutes on looking at some of the data of where that comes from to remind us why volume is so important. So volume and detection, one of the main cited sources is from Mackay's article in 1993 called The Detection of Bacteremia in Adults, Consequences of Culturing an Inadequate Volume of Blood. They both analyzed things that have already been reported in literature, plus reviewed data from 829 matched pairs of blood culture sets within their laboratory. What they found from literature and their own data was that the yield of pathogen recovery increases approximately 3% per ml that is cultured. 92% of the 69 bloodstream infections they saw were detected by standard volume, 7 to 10 mLs, but only 69% were recovered by low volume, which they considered 3.5 mLs. We can additionally think about blood culture volume as overall volume and how many sets of blood cultures are needed to identify bloodstream infections. Weinstein and colleagues published in 2007 on this topic, how many blood cultures are needed. They reviewed data from monomicrobial bloodstream infections that had 3 or more sets collected in a 24-hour period. Overall, between those with 3 and 4 sets of cultures, what they found were 73% of them, about 73% of them were identified with the first set. However, second set led to 89.7% of them being identified, and a third set was 98.3% identified. Additionally, the fourth set was approximately 99.8%. They also looked at the data by organism, which I think is really interesting, and showed that Staph aureus was more likely to be detected in the first set or two than organisms causing fungemia, such as Candida albicans and Candida glabrata. Bloodstream infections with gram-negative organisms were also lower percent positivity with the first set. So since we've discussed the concept of this pre-analytical specimen collection issues, I think it's important to understand the breadth of the issue. How common is it? So if we look back again to that Mackay article from 1993, part of it included a survey of microbiology lab directors that belonged to the American Society for the American Society for Clinical Pathology. They got 71 replies. And at that time, only 20% actually monitored volume. 26 different labs did provide data on the volumes that they received. An average of 12% of adult blood cultures had less than 5 mLs, with a range of 0 to 85%. And an average of 6% of adult blood cultures were received in pediatric bottles, with a range of 0 to 53%. And while this is older data and different regulations are in place, recently there was an editorial commentary in Clinical Infectious Diseases in 2020 that reported that anywhere from 20 to 97% of bottles are under the recommended 8 to 10 mLs of blood, and that fill volumes of 2 to 5 mLs are common. So why are there such issues with blood culture collection? What are the actual barriers that need to be addressed by the laboratory? Often cited issues include lack of knowledge about the sensitivity of blood cultures being so directly related to the volume of blood that is cultured, difficulty to gauge fill volumes during the collection process, lack of timely data collection and feedback, and the drawing process itself, how patient rooms are set up and how difficult it is to collect. Difficult to stick/draw patients, especially those that are of higher acuity. And staffing. Staffing includes lack of staff and staff turnover and use of agency staff. In 2007, Mayo Clinic Proceedings reported on results of an anonymous survey. There, they gave employees who draw blood cultures anonymous surveys, and they had about 355 that they were able to analyze. Of note, in this study, they were using 5 ml bottles as a set, so for a total of 10 mLs per set. What they found is 79% of people collected less than 10 mLs of blood in a bottle. 44% collected less than 5 mLs, and a striking 21% collected or thought that 1 ml was appropriate. So people who are actually doing the drawing of blood cultures are not aware of the actual volume that they should be drawing. It is now a College of American Pathology microbiology checklist item. Clinical microbiology laboratories must monitor blood culture volumes from adults for adequate volume and provide feedback to those blood collectors. Labs must have this defined in a procedure and have records of the monitor and feedback on inspections. Note, pediatrics are not included in this monitoring, as their recommended blood culture volumes are weight-based and typically significantly smaller volumes than adult, making it challenging to monitor. Quality assurance through structure and active monitoring and feedback has been shown to improve those specimen collection issues. So this is evidence that QA is incredibly important. This example is an article from 2020 in Clinical Infectious Diseases that looked at their monitoring process across a large healthcare system. They reviewed baseline data for approximately 4 months, then spent about 3 years implementing a quality improvement program using education, data collection, targeted communication, and bottle markings for collectors. Then they analyzed fill levels, pre and post implementation period. Looking specifically at the data from the largest hospital in the study, almost 2/3 of bottles or cultures had only 0 to 3 mLs pre-implementation, which they considered low. Post-implementation low volume samples were decreased to around 15%, and there was a significant increase in appropriate level draws and those that are over 10 mLs. Overall, there was a great improvement in that volume of blood cultured. And just to connect that back to the previous comments on increases in yield, they did review their percent positivity and correlated it to bottle fill. Over time, they saw an upward trend in positivity, with contamination rates staying approximately the same. In part C of this figure, they showed each hospital. The gray part of the bar is what would have been expected based on their historical positivity rates, and the red parts of the bar were the additional positives that they saw. Every hospital saw an increase in positivity that ranged anywhere from 5% to 54%. All right, so let's talk a little bit about a couple of the options. So manual monitoring is something that we were doing within our laboratory with our old system. And this was historically done by just visual estimation, utilizing dash marks in our facility. But other people do weigh blood culture bottles, and they do a calculation where they subtract a pre-inoculation weight of a bottle or an average of bottles, and then divide by 1.055 to adjust for the density of blood. Here's an example from our procedure with our worksheets that we had previously utilized. Quarterly, we monitored blood cultures coming in for a 24-hour period. Because this process was so manual and time-consuming, looking at manual recording and analysis of handwritten data, and clearly not very timely feedback. We didn't have a better way other than utilizing coded comments and pulling those report, but it would still rely on manual examination and remembering to document that in our laboratory information system. So, and remember, there are variations in every process. The visual inspection. Is the bottle exactly the same every time? Is the media in the bottle exactly the same, etc.? This melting clock represents the omnipresence of time and mastery over human beings. Again, we all suffer from workforce shortages and need to have ways to save time, become more efficient, and reduce variations in our data collection. Another way to achieve data collection is through automated blood volume measurement. Using an instrument to detect that blood culture volume leads to less manual variation. Yes, there are still errors that occur in things like we can't measure volumes in ones that have issues with label placement, but it is significantly more efficient, especially for our processing staff. And it may occur real time, but not in all vendors. Of note, I just want to point out that the Virtuo only measures adult bottles. Now I'm going to show you what it looks like to do this automated process. And this is an example of our MILA dashboard when we log into the system, highlighting that blood culture volume monitoring task. All we have to do is log into MILA and go to this blood culture volume section, and either we can build and run something manually, or our scheduled reports will just appear. And we'll talk about that more in a minute. I worked with our quality managers to identify the data that we would want to include or exclude from our reports. There are different styles of reports in here that we can choose from, including looking specifically at different institutions and collectors or by patient location. There's options to filter by bottle types, by patient age, which is something we set in just in case. The volume cutoffs that you utilize for different levels. So there's overfill, proper fill, and underfill can be set locally by whoever decides on it. So we currently are utilizing an underfill at less than 5 mLs. Proper fill is being 5 to 10 mLs and overfilled as over 10 mLs. But we may change those with time as we continue along our process improvement. Really, there are a variety of things labs can do and review in this building a report section. And in my opinion, once that is identified or those metrics are decided upon, scheduling those reports are incredibly helpful. Again, as any data pull goes, and I'm sure many of you pull data, you sit at a computer and that computer does have to spend time getting that data. And it does that with this as well. And scheduling it really allows it to run on its own and drop in here for you to go in when you can and just download it and spend less time worrying about it. And you also spend less time filling that data out with every report. So now I'll just show you a few examples of the types of the reports that we are utilizing within our laboratory. First, we're going to look at the ones that go over examples by institution and collector. This type of report is really helpful if you have unique collector codes for the people who are collecting blood cultures. The report comes with this basic, very visual bar graph representation of their blood culture draws, where red represents an underfill, blue a proper fill, and green an overfill based on the volumes that you have set in the system. It also includes alternate graphs with more information by code on maximum collection from a particular phlebotomist, minimum collections, what their average collection is, and then different percentile marks, which allow for visual review of that overall volume distribution from your blood culture collectors. The report also gives this in a data table for easier review of how many samples were actually drawn by particular collectors and the percentages and other data from those bar graphs in raw form. To me, this part really helps us identify problems with particular collectors for those who are drawing more cultures, because you get to see and analyze the information on exactly how many samples were analyzed, giving more power to those results because that N value is higher or lower. And I'll show you an example of that shortly. Next, more recently, when reviewing the system with our quality department, we found this option to trend by institution and collector. So we decided this would also be beneficial for feedback as you really kind of get a bigger overview of the behavior that's happening of particular institutions and collectors over a larger time frame than just the 1 month. And again, you can set by how long these pull. So basically the same types of data are pulled, but by each month. And so this is an example of one for a particular institution instead of a particular collector. And this shows January through June 2022 of that particular hospital of ours. But additionally, you can get collector level data to be reviewed over that specified time period of the report you're pulling. So here I'm showing data from one collector, which Again, if you look at the visual bar graphs, it looks like he or she, I should say, significantly improved in their proper fill as they went to all blue graph. But when you look at the data table, he or she has 16 in that first month and only a couple of cultures this last month. So that would give a little bit less weight to saying that she might be adequately recovered from or retrained from her drawing. But obviously, I tell people I will commend anyone with a proper fill of 100%, regardless of the number of draws there is. But we could still look at this and say we have to continue to monitor this particular employee to see if she maintains that level. So how are we currently using these reports? Again, we're running them by institution and collector monthly, but also running a trending by institution and collector quarterly to help monitor our efforts in retraining and feedback, especially when we identify any major issues with one of our collectors. And we can review then if they've attended the retraining sessions or been assigned the competencies in our document control system like they should have been. We send these reports out to the managers of the laboratory, the managers of the phlebotomy sites, and to nursing directors across all the different hospital areas. We have some opportunity for improvement, however, to include ensuring better follow-up for non-compliance, since it is a newer tool for us and we're still developing our response plan. In summary, blood culture volume is the most important factor in the recovery of microorganisms from bloodstream infections. The microbiology laboratory plays an incredibly crucial and critical role in antimicrobial stewardship. The use of timely feedback and education on blood culture volume requirements has shown to improve both blood volume drawn and the recovery of microorganisms. And the use of automated reports improve the timeliness of feedback and efficiency within the laboratory. I want to thank you all for listening to my talk today. Laboratory professionals are an integral part of the healthcare system. So I also want to thank you for being involved in patient care and say Happy Lab Week.